Good morning. Fort Wayne is so lucky to have Dr. McMahon. One of her greatest talents is that she is incredible at engaging the community. Whether you're a community leader, a physician, she wants to know who you are and what impact you can have on all of these health disparities and outcomes. I moved to Fort Wayne about 6 months ago, and within 2 days of me arriving, she called me on my cell phone. I don't know how she got my cell phone, but she called me, and we started work immediately on the substance use disorder issue in pregnancy, and we've made some tremendous outcomes from that. So thank you, Dr. McMahon. My name's Tony GiaQuinta. I'm a Fort Wayne pediatrician, and I'm the president of the Indiana American Academy of Pediatrics. My organization is composed of over 900 pediatricians from around the state. We are nonpartisan. We are pro-children. We don't have trouble parsing political agendas because we always have a common North Star, and we always put children first. I'm here to tell you about a story of one of my early failures as a pediatrician and what engaging families really means to me. I present this not as a lecture to other doctors, although I do see some prominent physicians in the room, but rather a challenge to a really proud community that must solve some very important and very devastating health disparities, not only in our community, but our state and our country. The story starts in my residency in Nashville, Tennessee. As part of our training, we're giving a panel of patients to try our hand at becoming pediatricians for the first time. My panel had about 30 patients on it, which, for perspective, I see about 25 patients a day. So it's not a ton of patients. And as an intern in my residency clinic, we get these extra time with their patients, which is really important because we have a ton of questions about their development and pool and sun safety and on and on. And my greatest fear as a newly minted MD was that I might miss something. So to prevent that, I'd bring in this long list of patients list of questions to every health maintenance visit. And we'd go through the list with every family ad nauseum until I was sure that every medical cabinet was locked up and every water temperature was set to 120 degrees and every gun cabinet was also locked. So when the ER paged me one night of my intern year to tell me that one of my 30 patients, a 1-month-old, had died of sudden unexpected infant death syndrome, I was incredulous. The report admittedly made me angry. He died sleeping with his parents on a blow-up mattress, and I, of course, had talked to them over and over again about the ABCs of safe sleep: alone, back, crib, alone, back, crib. How could this have happened? Statistically, maybe I shouldn't have been quite so surprised. After all, our country owns the highest infant mortality rate of all the industrialized countries, where 6 out of 1,000 babies die before their first birthday. But it wouldn't be until much later that I learned that this infant, an African-American male born into poverty, was at a much higher risk than his wealthier, whiter counterparts. I took care of his other children, which is why eventually we would be sitting in my office, me offering impossible condolences. It was then that I learned that the bassinet that they bought secondhand was ridden with bed bugs, and it had to be pitched. The blow-up mattress that they were all sleeping on, that was the only conceivable option. That scenario was not in my pediatric manual. And for all my medical training and desperate desire to be a good, thorough pediatrician, I realized then that I was doing it wrong. I could have had twice as much time lecturing them about safe sleep with this family, but it wouldn't have helped. I did not engage that family, and I did not see what they needed. I didn't see what their struggles were, and I didn't have a clue what living in poverty really meant for them. Solving the infant mortality dilemma became my passion from then on, and I dedicated my early career to infant mortality initiatives. After moving to Indianapolis, I became the infant mortality chairman. So it was with great excitement that in 2012, our governor announced that infant mortality would be the Indiana State Department of Health's #1 priority. That plan included steps to reduce prenatal smoking, low birth weight, and deaths from sudden infant death syndrome. So I don't mean to criticize that strategy because I know from experience that all of those objectives are important for addressing infant mortality. And I know from experience that moving that needle of infant mortality is very difficult. But for all that effort, for all that prioritizing, this is where we are 5 years later. Our infant mortality is that orange line. It hovers around 7 and 8. 2012, our infant mortality was 6.7. 2016, which is the latest data, we are up to 7.5. That is higher than our national average, which, as I mentioned, is devastatingly high. So what can we learn from this? Well, number one, addressing infant mortality, like I mentioned, is just not that easy. To know thy enemy, you have to know everything about them. And as you can see, there's a lot of different things that we can pick to try to address infant mortality. Number two, we haven't moved the needle. And number three, we need a different approach. We need what I would argue is a public health strategy. Addressing infant mortality isn't like just picking a couple of these things and throwing them on a wall and hoping they stick. It requires evidence, it requires research, and it requires a financial incentive and a financial investment. We've talked about this many times, but there's Indiana. This is our public health funding. We are 49 out of 50. This is not a strategy. Hope is not a strategy. We can do better. I'll get back to this, but for now, I want to get back to my Fort Wayne story. So, as infant mortality chairman living in Indianapolis, I would be presented with these data points of the top 10 zip codes in Indiana for highest infant mortality. And every year I would see a common zip code on that list, Allen County 46806, an infant mortality rate of 15.3, a black infant mortality rate of 24 compared to a white infant mortality rate of 7.5. So here you can see that something awful is happening. What's more important is that we can put lines around that area. This is where it's happening. This isn't a third world country. This is our community. Between these lines, something truly terrible is happening. We can see it. We can drive through it. I went to school there, Weiser Park. What are we going to do? Well, the next year, this data came back, and I was still in Indianapolis, and once again, Allen County 46806 is at the top of the list, this time third. Infant mortality rate now up to 22 for black children. But then another player came in, 46805, and I knew then that my wife and I had a new calling, which was to come back to Fort Wayne to help lead this effort, this initiative, or at least bring awareness to this terrible, terrible trend. So I was lucky to find a job in the middle of that battle, and I joined a practice with an 80% Medicaid population that needed more than just vaccines and developmental screens that all pediatricians provide. And I mentioned earlier that our public health leaders might hold the key. Well, lucky for me, I married one. And so I went to her and I said, I need to offer my patients a different experience. I need help engaging them to really find what really matters to help move this needle of infant mortality. So she developed this. This is a screen that I don't think anybody has ever seen before in a pediatric office. These are not typical questions that a pediatrician would want to ask because this is a very complicated onion that when you peel back, you're going to get some really complicated answers. And you're going to need a strategy when you do get these back to make sure that we are plugging them into the resources to help them thrive and get these questions addressed. But there they are. Do you feel unsafe in your home? Are you worried that something in your home is making you sick? Would that include bed bugs? Would that include calling 211 because that's where this survey would direct you to direct you to the health department to get that assessed, and maybe to a community nursing program that would get you a safe crib to sleep in? That's my hope. But more importantly, this is a strategy. This is a strategy. It's one based in public health with research that we are going to study, and that I hope is going to maybe save lives. Save lots of lives. One life. All of those lives would be important. This is just one example of how public health can make a difference in our community. And a lot of this, with the emphasis today, is raising the cigarette tax. Raising the cigarette tax is absolutely the best way to reduce smoking in a community. It has been well studied that when you raise a tax, less people will smoke. And the downhill effects from that, downstream effects of that, will be seen immediately, some of them related to infant mortality as well. But what's really important, what this room has to understand, is that the opportunity to double down on that investment is here. So when we get that money back from that cigarette tax, we have to be loud and together in voicing that that money needs to go back into public health. The leaders are in this room. We are ready to go. But as Dr. McMahon mentioned, it's about money, and we need the funding to help drive these initiatives. Whether it's obesity, where I can see patients for obesity, but I have nowhere to send them, or whether it's tobacco smoke, where I can talk to them about the dangers of tobacco, but needing to funnel them into a tobacco cessation program, all of these steps are going to require more than just talking and lecturing. They're going to require engaging and offering a plan to these patients from a public health perspective to help really move these difficult needles in public health. I know I'm running a little short of time, but basically that was my main theme for the rest of this, is just making sure that when we do transition and engage our public health leaders, that we're not just talking about a tax on cigarettes and the importance of driving down our tobacco cessation rates, which is very important, but also about reinvesting that money back into public health so that we can move that 49 up into a much higher percentile and make a difference for our community. Thank you.